The title of my presentation is Prescriptions for Opioid Analgesics, Verifying the Prescriber Got It Right, the Pharmacist's Corresponding Responsibility. This is more than just a snappy title. When I first was asked to give this presentation, I thought, oh, that's just catchy lingo. No, this is FDA regulation, so I would hazard a guess that this is a topic that most pharmacists don't even know about, and it's critically important. My learning objectives are shown on this slide. At the conclusion of this session, the participant will be able to review the terms legitimate medical purpose and corresponding responsibility as they apply to the use of opioid analgesics in the treatment of chronic pain. And we'll sprinkle some case studies throughout to identify examples of appropriate and inappropriate prescriptions for opioid analgesics. And along the way, we'll talk about barriers associated with chronic pain treatment and opioid therapy to include concerns of safety and efficacy, potential for drug misuse and addiction, and healthcare providers' fear of regulatory scrutiny and legal sanctions. Well, I guess this is sort of required that we start off with what the heck is pain before we jump into how can we get into trouble and stay out of trouble. This is a quote from an advocate for people with chronic pain. It is so much more than just the pain intensity. Over time, many patients find the effects of living with chronic pain impact their ability to work, engage in recreational and social activities, and for some, perform the most basic everyday activities that people take for granted. Not surprisingly, pain begins to chip away at their mood, often leaving them angry, frustrated, anxious, and or depressed. Our families suffer along with us, and many relationships are forever altered. You have to admit, that sounds pretty grim. This is the International Association for the Study of Pain definition of pain: an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in terms of such damage. Pain is always subjective. It is unquestionably a sensation in a part or parts of the body, but it is also unpleasant and therefore also an emotional experience. So I do think the important words there are sensory and emotional and actual or potential tissue damage. But clearly, pain is subjective. If somebody tells me their pain is a 7, I can't draw a blood test, run it down to the lab, and say, oh, look, you lie like a rug, it's only a 4. So why do we worry about chronic pain? If you look at the statistics or the prevalence of different diseases, I think we would agree that diabetes, heart disease, stroke, and cancer are pretty prevalent in society, pretty big players here. But if you add up all the people who have those disorders, it totals about 61 million people. If you look at the Institute of Medicine report from 2011, people with chronic pain number 100 million. So more people have chronic pain than does everybody with the diseases shown in the top half of the slide. If you look at the prevalence again from this point of view, age-adjusted rates of U.S. adults reporting pain in the last 3 months, almost 30% report low back pain. Wow! And then it goes down from there, but that is a lot of people. How about the extent of pain-related disability among adults with pain in the last 3 months, according to 2009 data? If you look at low back pain, 30 to 35%, it impacts basic actions and complex activities. Even worse with knee pain, about the same with headache and neck, and it goes down from there. So pain has a significant impact on quality of life and ability to do your activities of daily living. The trends in pain prevalence from 1999 to 2004, as you can see, as we get older, the risk is greater. And as time has gone on, it has gotten more prevalent as well. Some additional facts about pain. Over 50% of hospitalized patients had pain in their last days of life. 50 to 75% dying in moderate to severe pain. Boy, that really hits me where I live because I do hospice and palliative care as a big part of my practice. And about 20% of Americans, adults, report pain or physical discomfort that disrupts their sleep a few nights a week or more. Chronic pain patients receiving opioids, over 50% state they still have little or no control over their pain despite getting opioid therapy, and the majority, 6 out of 10, still experience breakthrough pain despite getting opioid analgesics. And the impact on quality of life, about 2/3 report an impact on overall enjoyment of life, over 70% report depression, trouble concentrating, reduced energy, and again, the vast majority report an inability to sleep well. So why are we doing such a not great job in controlling pain? I think we can look at barriers, and they can be system level, clinician level, or patient level barriers. Some examples of system level barriers are things like failure to routinely implement strategies to address the biological, cognitive, emotional aspects of pain through a comprehensive and interdisciplinary approach to pain management. It really takes a village to treat pain appropriately, both the assessment and the management of the pain. And so often what we see is clinical services and research are performed in siloed, disease-specific fashion, not as a collaborative interprofessional effort. Some clinician-level barriers include things such as some pain conditions have no treatment guidelines. Certainly, I think physicians, pharmacists, nurses, other providers don't get a good grounding in pain management in their professional training. It's difficult for primary care practitioners to identify and engage other clinicians. We don't have enough pain specialists in the United States. Some people don't understand the importance of good pain management and the consequences of not doing a good job. Regulatory law enforcement policies constrain the appropriate use of opioids. We're seeing that increasingly on a state-by-state level. Insurance coverage restriction, and we certainly need more basic and clinical research. And then there are a lot of patient-level barriers as well. Pain patients are closely scrutinized. They feel like they're really under the microscope. We do have people who try to scam the system, which are far, far fewer in number than legitimate pain patients, but they are there, so we have to be on our guard, which really is the whole thrust of this presentation today. Some patients do doctor shopping, and we do see undertreated vulnerable populations such as women, children, people of certain ethnic and minority groups, and people of lower education and income. So how do we treat pain? If we sort of look at this four-step approach, most people start off with self-management, which is maybe using a non-prescription drug. What's kind of scary is possibly in consultation with family and friends. We really don't want Aunt Betty sharing the love from her medicine chest, if you know what I mean. Then we kick it up a notch where patients will go to their primary care practitioner, which could be prescription drugs certainly, and primary care practitioners love to recommend exercise, physical therapy. Weight loss is a big part of this, particularly with osteoarthritis. We may have to kick it up a notch and go to a specialist, either in the underlying disease like arthritis, for example, or maybe a neurologist for a headache disorder, or perhaps even a pain specialist. And then the highest level is going to be interdisciplinary, interprofessional, multidisciplinary approach at a pain center. What's the dealio? We have all the tools that we need to treat pain. So why are we seeing all the concern and all the data coming out about prescription painkiller overdoses? Well, I think everybody knows that we have two competing public health crises in the United States. One is that, as shown on the left, those 100 million people who have poorly controlled pain. And on the right, a history of drug abuse and diversion. So, we have got to be so careful to protect ourselves and patients and prescribers and society as a whole, while on the other hand, making sure we still get the job done to take care of patients who have pain. This is data from the CDC showing that for every one death due to opioid overdose, there are 10 treatment admissions for opioid abuse, 32 emergency department visits for misuse or abuse, 130 people who abuse or are dependent, and 825 non-medical users of controlled substances. This is really scary, I think. Where are these prescription painkillers coming from? So if you look at the lighter blue, they're the smaller triangle, got the drug from a dealer or a stranger. So that's like one of the smallest sources. The orange one is took from a friend or relative without asking. The gray is bought from a friend or relative. The yellowish rather, is prescribed by one doctor. The blue, which is the biggest part, over 50%, obtained free from a friend or relative, and then the green is some other source. This is just a slide looking at, as we've seen the years roll by from 1999 through 2009, over that decade, we saw an increase in opioid pain reliever deaths per 100,000 people, which very nicely paralleled along with treatment admissions and opioid pain reliever sales. So we have more drugs out in circulation, it's causing more admissions to ERs and hospitals, and it's causing more deaths. Further looking at the scope of the problem, this blows my mind. In 1997, opioid sales in the U.S. were equivalent to 96 milligrams of oral morphine per person. By the year 2010, that had gone up almost tenfold to 710 milligrams per person. This is the equivalent of taking a hydrocodone 5 milligram tablet 4 times a day for 45 days for every single adult in the United States. That is a lot of hydrocodone. We use 99% of the hydrocodone in the world in the United States. It was the most number one dispensed drug from 2006 to 2012. And again, we have less than 5% of the world's population, but we consume 83 and 99% of the world's oxycodone and hydrocodone respectively. This is just a slide showing you the growth of the sales. As you can see here, even methadone, which I do like methadone for chronic pain, whether it's cancer or non-cancer, but boy, you better know what the heck you're doing with methadone dosing or somebody's going to get into big trouble. 20% of Americans use opioids for non-medical purposes, whether it's to chemically treat depression or anxiety, to get high for whatever reason they are using them for. 7 million Americans over the age of 12 report using psychotherapeutic drugs for a non-medical purpose in the past month. That is a lot of non-medical use. Opioids in chronic pain patients. 5 to 41% of patients receiving opioids for chronic non-cancer pain have been found to be abusing these drugs. And among patients with chronic pain who do get opioids for their treatment, a little over 3% do develop an addiction, over 11% develop aberrant drug-related behavior or use of illicit drugs, and about 20% divert the opioid. So these are really scary statistics. And actually, Janet Woodcock, the physician who's pretty high up there in the FDA, published in 2009 in New England Journal of Medicine her own little scales of justice here, saying, boy, this really is a tough balancing act between pain management, drug safety, and what's the FDA to do? They're trying to protect the public too, but they don't want pain patients to suffer either. So, boy, this really is a conundrum. So, where's the beef? I mean, I guess if you're old enough to remember the commercial, where's the beef? What's the sitch? Why is everybody all up in arms about this? I think we have seen clearly, as I just shared with you, an increase in the use, misuse, and abuse, mostly of oxycodone and hydrocodone, but the other opioids as well. Certainly, if you look at methadone, methadone is probably responsible for fewer than 5% of opioid, it's implicated in cases of fewer than 5%, but responsible for about 30% of the deaths from opioid-induced death. Fictitious prescriptions were dispensed by rogue internet pharmacies from 2004 to 2008 for people without a true medical need. So this was the 4-year span where we really saw the internet prescribing for, so clearly illegitimate use of controlled substances. And then we saw the rise, and still do see, the pill mills, where we saw truly legally licensed and registered practitioners who are prescribing controlled substances, but for non-legitimate medical purposes. So we still see this going on. So it's kind of like a prescriber for hire, who they'll do anything for money. They're happy to give you the prescription in exchange for cold hard cash. So the DEA has recognized, boy, the game is changing here. People who want to abuse medications know that going with an FDA-approved product is certainly safer. You got all that quality assurance going on. I mean, who wouldn't rather get a nice bottle of something from the pharmacy than something that you buy from behind the high school somewhere? So the game has changed. So the DEA has said we can't just rely on saying, oh, you are a licensed prescriber, so it's got to all be good. They have to rely on others to be gatekeepers. So per the FDA, where does the buck stop? Well, that's the whole thrust of this conversation. Prescribers. So the DEA has said a prescription for a controlled substance to be effective must be issued for a legitimate medical purpose for the proper prescribing and dispensing of controlled substances is upon the prescribing practitioner, and who else? But a corresponding responsibility rests with the pharmacist who fills the prescription. So it's not just the prescriber, it's also us as pharmacists who have a corresponding responsibility. The DEA continues. An order purporting to be a prescription issued not in the usual course of professional treatment or in legitimate and authorized research is not a prescription within the meaning and intent of Section 309 of the Act, and the person knowingly filling such a purported prescription as well as the person issuing it. So basically this is the prescriber and the pharmacist here. Both shall be subject to the penalties provided for violations of the provisions of law related to controlled substances. So if it's not a legitimate or appropriate prescription, everybody's going to be in trouble. So it can be legitimate but not appropriate, and still we are held accountable for that. So both the prescriber and the dispenser are held liable here. So, what is this term legitimate medical purpose? The term valid prescription, per the FDA, means a prescription issued for a legitimate medical purpose in the usual course of professional practice by a practitioner who has conducted at least one in-person medical evaluation of the patient, which largely includes physical exam and history taking, or a covering practitioner. So the term in-person medical evaluation means a medical evaluation that is conducted with the patient in the physical presence of the practitioner, meaning not over the internet, without regard to whether portions of the evaluation are conducted by other health professionals. So you can't just phone it in. A prescriber has to see the patient. They can't just write a prescription and mail it or call it in somewhere without seeing the patient and conducting good medical practice of laying eyeballs and hands on the patient, doing a history and physical. So the DEA has provided some examples of what is not legitimate medical purpose. Issuing prescriptions for controlled substances without a bona fide physician-patient relationship. I think everybody would kind of agree issuing prescriptions in exchange for sex is not a good look. Issuing several prescriptions at once for a highly potent combination of controlled substances, such as we saw with Mr. Smith in our case. Charging fees commensurate with drug dealing rather than providing medical services. So the more drugs you want, the higher your office fee is going to be today. That certainly is not the kind of sliding scale that would be appropriate. Issuing prescriptions using fraudulent names, either a real person's name but not the person that the physician saw, or a made-up name. And then self-abuse of controlled substances by practitioners. Obviously that's not a good look either. So this is actually, I've given you the citation on the bottom of the slide. This information this is a list of indicators from the DEA of diversion and abuse and non-legitimate prescriptions being written by a physician. And this all came from a case from 1978. Dr. Isidore Rosen, who was a 68-year-old physician, when he was 68 years old, this physician from a rural area in Louisiana gave up his general surgery obstetrics practice due to his age. And then for the subsequent 7 years, he decided to take to more of an obesity practice, and it became about 60% of his practice. He was charged with 25 counts of dispensing and distributing controlled substances illegally. What was happening is he prescribed FDA-approved controlled substances for weight loss over a year that he was under investigation, from July of 1976 to March of 1977. And they really focused on, the whole case was really 6 undercover law enforcement agents who were posing as patients. So to convict him, the government had to show 3 things. 1, that he distributed or dispensed controlled substances. And he said, yep, I certainly did that. Number 2, that he acted knowingly and intentionally. And he said, yep, I did that too. And number 3, that he did so for other than a legitimate medical purpose in the usual course of his practice. Now, he claimed that he thought they were legitimate patients and that he did his medical thing, which was usual and customary, and he prescribed FDA-approved controlled substances to treat their obesity. But the government argued that the pattern of distribution of the drugs that he chose and often dispensed on his own, pulled them out of his desk drawer, clearly showed that dispensation was not done in good faith for legitimate medical treatment. An important conclusion that was made was a licensed practitioner is not immune from the act solely due to his status, but rather he is expected to prescribe or dispense drugs within the bounds of his professional practice of medicine. So this is the list of things that they came up with from this case. For example, inordinately large quantities of controlled substances were prescribed. Large numbers of scripts were given. No physical exam. The physician warned the patient to fill the scripts at different pharmacies. The physician issued prescriptions knowing the patient was giving the drugs to other people. The physician prescribed controlled drugs at intervals inconsistent with legitimate medication treatment. The physician involved used street slang rather than medical terminology for the drugs prescribed. There was no logical relationship between the drugs prescribed and the treatment of the condition allegedly existing, and the physician wrote out more than one script on occasions in order to spread them out. So if you've got some time on your hands, go to this link. It really is interesting to read it. They've even even quoted in this document some of the conversations that this physician had with these law enforcement officers who were posing as patients. Things like, I don't care what you do with them, let the cops bust you, I'm going to keep you on this medicine. And then he reached into the drawer and took out 2 more bags full of drugs. Take this to this independent pharmacy, take to Village Pharmacy. He said, if the police stop you, say that you got a 2-month supply because you're going to leave town. On 2 separate occasions, he told a female patient, I'll give you anything that you want. And using the slang drugs such as black mollies, and I am or I'm not going to give you black mollies at this time. So this is kind of interesting. This is kind of where where we are today. It really started. This is a superb paper written by Dr. David Brushwood, published in the American Journal of Health Systems Pharmacists, talking about what the heck is a legitimate medical purpose. So he really goes through, first talking about the Department of Justice does not have the authority to determine which healthcare activities constitute legitimate medical purpose under the DEA regs. This authority rests with each state, so it's not a federal issue. However, the Department of Justice can intervene if a physician or pharmacist is engaging in activities outside the realm of healthcare, such as selling controlled substances to drug dealers, and clearly there's no therapeutic purpose. But the Department of Justice cannot tell a pharmacist or physician what constitutes acceptable healthcare practices. So then he goes into what is a legitimate medical purpose. So he talks in his paper about we cannot begin to say this is a legitimate medical purpose until we can say this is an illegitimate medical purpose. But there really is no illegitimate medicine. A practice that is not legitimate is not medical. So he says the terms legitimate and medical are redundant, so the phrase legitimate medical purpose can be reduced to just medical purpose without losing any meaning. Because a practice that is not medical is not legitimate or legal under DEA regulation. But if it is medical, it is legitimate and is under DEA regulation. So bottom line is the DEA does not regulate within a medical practice, but simply discerns whether a practice is medical or non-medical. Also, the DEA recognizes that its responsibility is to prevent drug abuse and not to interfere with professional practice. In an article published in 1983, the agency's Associate Chief Counsel said, and I quote, "Acts of prescribing or dispensing of controlled substances which are done within the course of the registrant's professional practice are, for purposes of the Controlled Substances Act, lawful. It matters not that such acts may constitute terrible medicine or even malpractice. They may reflect the grossest form of medical misconduct or negligence, but they are nevertheless legal." So it's been very interesting preparing for this presentation, reading up on how do you define these terms. It's kind of subjective, I guess, in a way. So what can we do to help us with this? Well, the Federation of State Medical Boards is a group that is committed to assisting medical boards at the state level in protecting the public and improving the quality and integrity of healthcare in the U.S. In 1997, this group undertook an initiative to develop model guidelines and to encourage state medical boards and other healthcare regulatory agencies to adopt policies encouraging safe and effective treatment of patients with pain, including, if indicated, the use of opioids. So they're trying to give guidance to the state medical boards. They started this in 1997. They were updated them in 2003, and they've been updating them ever since. So this is kind of what they came out and said. The board will consider the use of opioids for pain management to be for a legitimate medical purpose if it is based on sound clinical judgment and current best clinical practices, is appropriately documented, and is of demonstrable benefit to the patient. And then they go on to say, to be within the usual course of professional practice, a legitimate physician-patient relationship must exist, and the prescribing or administration of meds should be appropriate to the identified diagnosis, accompanied by careful follow-up monitoring of the patient's response to treatment, as well as his or her safe use of the prescribed medication, and should demonstrate that the therapy has been adjusted as needed. There should be documentation of appropriate referrals as necessary. And then their whole document, and I've given you the PDF site here where you can pull down the whole document, goes into much greater detail going through what they mean by each of these statements. But at least it gives us a little bit of guidance on what the heck is legitimate medical purpose. So now we come to the real crux of it. What does this mean for pharmacists now that we've gone through this legitimate medical purpose? pharmacists also have this corresponding responsibility. What does this mean? Bottom line, it means the pharmacists are also, quote, on the hook for the veracity of a prescription. And this is not tied to any numerical safe harbor. You can't just say, number one, you can't just say Dr. Smith is a licensed prescriber, so if he thought this was the appropriate thing to write, I'm good to go, because it's a legal prescription. So it could be legal, as I just went through, all that stuff that the DEA said, but it may not be legitimate, or it may not be appropriate. We are still on the hook for that. And you cannot also just say, like some states say, oh, no, prescriptions over 100 milligrams of oral morphine equivalent a day. Or we can't just look at certain opioids that have been really associated with misuse and abuse, such as hydrocodone and oxy. And it's not a tablet or capsule limit that we can look at. So we have to look at the whole picture. What are the consequences for pharmacists who don't embrace this obligation? We are seeing criminal prosecution, fines, incarceration, probation, criminal proceedings, and then also administrative measures by the Board of Pharmacy, which could include fines, suspension, and practice restrictions. So to be subject to legal penalties, the pharmacist must be knowing in most cases. So how could a pharmacist get in trouble? There are two ways. If they knowingly fill a prescription that is illegitimate. Number one, if the pharmacist knows it's illegitimate. For example, the pharmacist faked the prescription and then filled it. Obviously, that's pretty over the top, and that's clearly illegitimate. But the second one, where I think pharmacists really get into trouble because they don't think about this, is when they're on cruise control and don't know or don't care, and they recklessly disregard whether the prescription is for a legitimate medical purpose. And that's known as reckless disregard, because you don't know or you don't care, and you just go ahead and dispense the prescription. So this is a list from a REMS education program looking at some possible risk factors for a prescription for non-legitimate medical purposes. Now again, you can't just hang your hat on any one of these. So a younger patient, a lot of younger people have legitimate pain, and it would be entirely appropriate. And not everybody who pays cash is a naughty kitten. I think this is sort of like looking at how many red flags do you have. A large quantity by itself is not an indicator there's something weird going on. The doctor located far away. Maybe the patient lives in the boonies. Maybe they don't. Late at night, they present right before you close. The script is missing information. Patient appears like they're very nervous or in a hurry. Continuing on, early refills without a change in direction or some other good reason. The patient comes in with a fistful of prescriptions, but the only thing they want filled is the controlled substance. This is my favorite. Something just doesn't look right. JDLR. Or I've always heard this as SARS, something ain't right syndrome. And this is another one that makes me crazy. Prescriptions from emergency rooms, and I added here, or from a dentist with a large supply order, like a 90-day supply. There ain't nothing the dentist is going to do to you that's going to warrant a 90-day supply of Vicodin. And of course, we all know that you do not have to fill every prescription that crosses your counter. So this is what I mean by looking at those red flags. This is an interesting case. I've given you the link here too to read this more carefully. It was very interesting reading. This is a fairly recent case. In April of 2009, the DEA issued an order to show cause to East Main Street Pharmacy for reason that continued DEA registration is inconsistent with public interest because the respondent, the pharmacy, had violated its corresponding responsibility under federal regulations to not fill unlawful prescriptions. And in fact, if you can finish reading the document, their DEA certificate of registration was suspended in October of 2010. So the investigation covered from September of 2005 to February of 2006, where the pharmacy filled over 6,600 controlled substance prescriptions, including almost 5,000 of the 6,600 written by one physician, a Dr. Paul Volkman. Most of the prescriptions were filled in exchange for cash. 98% of the patients did not live in the area. Most of the patients had prescriptions for polypharmacy, opioids, benzos, and carisoprodol. Patients often had early and overlapping refill prescriptions. The physician's license was suspended in February of 2006 for, quote, repeatedly violating federal law by prescribing controlled substances without a legitimate medical purpose and outside the course of professional practice. So based on this case, the DEA came up with a list of the pharmacist there, and it was one pharmacist who owned the store, ignored several signs that the prescriptions were not legitimate. And frankly, of these 10 key points that they have, and I've shown here on this slide and the next one, they said numbers 2 through 10 were gravy. They were icing on the cake because number 1 was enough that the pharmacist should have said, My corresponding responsibility tells me that this right here is a huge red flag, and I should have no part to this. Number one, ample evidence, as evidenced by 5,000 prescriptions, showing the respondent repeatedly dispensed cocktailed prescriptions for oxycodone, hydrocodone, alprazolam, and carisoprodol. Icing on the cake, no individualizing the dosing, so everybody, all comers, all patients got the same drug, same dose, same regimen. Filling multiple prescriptions for the strongest formulations of 2 of the drugs, requests for dispensing or early refills, refilling prescriptions of patients or doctors located hundreds of miles away from the pharmacy. An overwhelming proportion, 95% of the prescriptions filled by the pharmacy were controlled substances. So that was the vast majority of his business. The pharmacist did not reach out to or otherwise contact other pharmacies to determine why they were not filling a prescription or particular doctor's prescriptions. Filling prescriptions of patients that traveled to the pharmacist in groups. Seriously, how can you not think something's amiss when 10 people show up with a prescription for an opioid, all from the same prescriber, and they're all going to pay cash? How can you not know that something's up? Filling a larger percentage of case prescriptions and verification of a prescription as legitimate was not satisfied because the practitioner performed MRIs and blood tests on the patients. I was just doing an internet search a couple days ago, and this is in my area. I live in Baltimore. This is in Glen Burnie. A Glen Burnie pharmacist has just started payments on a $100,000 fine based on the failure to meet his corresponding responsibility. Just recently, this hit the news. A woman in Milwaukee, Oregon has sued her physician and the pharmacy that dispensed her medication over a 2-year period, and she claims this is for causing her to become addicted and enduring excruciating withdrawal. This is a 49-year-old woman with chronic pain and diabetic thoracic radiculopathy. From 2010 to 12, she was prescribed an average of 26 oxycodone tablets per day, either 15 or 30 milligrams. The patient claimed this caused her to lose her teeth, her vision. She had headaches, nausea, numbness in her hands, and for 8 months of this time period, the physician would only speak to her by phone and issued the prescription. She did change physicians and she was weaned off, but she is suing for $1.5 million. And you know what? I think that, she may have a case here. I'm sure as everybody has heard what happened in June of this past year, where Walgreens tangled with the DEA after a dramatic increase in oxycodone doses were dispensed by Walgreens pharmacies in Florida. Walgreens and the DEA did enter into a memorandum of understanding or agreement where Walgreens was fined the $80 million. They did surrender the DEA registration for 6 of their Florida pharmacies until May of 2014, and its Jupiter Distribution Center until September of 2014. And then Walgreens did develop their good faith dispensing policy to guide pharmacists in dealing with prescriptions for controlled substances. And initially part of this guidance for the pharmacist was to contact the prescriber for all controlled substances. I believe that has been changed somewhat. They don't mandate that at this point. But based on that, the American Medical Association fired back and said, baby. They came up with 2 resolutions that they passed just this past year. Resolution 218, they deemed inappropriate inquiries from pharmacies to verify the medical rationale behind prescriptions, diagnoses, and treatment plans to be an interference with the practice of medicine and unwarranted. And then resolution number 12, drugstore requirements for verification of the rationale behind scripts, including diagnoses, treatment plan, ICD-9 codes, and or previous meds or therapies tried, failed, and for routine pharmacist calls such as verification of this rationale to be inappropriate interference with the practice of medicine. So, this has been a real firestorm. I think the AMA was firing this as a warning shot, saying, don't mess with us. And I don't think this was really the intent. I don't know. It's kind of a mess, but we'll see how the dust settles on this. I have not heard anything more that the AM is going to take this any further. In my opinion, this is just my opinion, I think this was a warning shot, like, don't even think about going there. And I understand that, Walgreens pharmacists are not mandated to call on every controlled substance at this time, but in fact encouraged to use good professional judgment. I'd just like to take a second and say, wait a minute. Let's, in our zeal to meet our corresponding responsibility, let's not forget about the pain patient. So let's not throw the baby out with the bathwater. If somebody complains of pain, you can easily ask about their complaint of pain. What brings it on or makes it worse? What makes it better? What have you tried? How well did it work? Tell me how the pain feels in your own words. Where is the pain? Does it move anywhere? How bad is the pain? Temporal, and how does the pain affect you? So assessing the complaint of pain. Assuring good pharmacotherapy and the use of non-drug interventions. Certainly many painful syndromes are amenable to treatment with acetaminophen. It's indicated for mild to moderate non-inflammatory nociceptive type pain. Granted, acetaminophen is mostly useful for self-limiting painful conditions such as a headache, mild to moderate musculoskeletal pain, dental pain. It's still considered first line in low back pain and osteoarthritis. Then we could kick it up to the nonsteroidals, which are indicated to lower a fever or mild to moderate pain that may be inflammatory in nature. This could be acute or chronic, and nonsteroidals are particularly effective in certain types of pain that are somatic, muscle, joint pain, bone or dental pain, inflammatory and post-op pain. And the nonsteroidals do have an opioid-sparing effect, but they do have a lot of adverse effects, including cardiovascular risk, and cerebrovascular risk is elevated, and the GI issue and the renal issue that we worry about, of course. And again, these are some of the indications for nonsteroidals. Opioids, we certainly have plenty of opioids. You can pick a phenanthrene, benzomorphin, phenylpiperidine, and so forth and so on. The indications for the opioids, now you can see in the past year we've seen moderate stricken from the labeling of the opioids. So the opioids are now treatment of severe pain that does not respond to non-opioids alone. We use opioids to treat cough, diarrhea, dyspnea, and opioid dependence in addition to pain. So the role in painful pain can be any one of these as shown on this slide. I think this is an important slide for pharmacists, is knowing not every single pain on earth is going to respond well to an opioid. There's this term called pseudo-resistant, meaning, yeah, an opioid's right, it's not working because either your dose is too low, maybe the patient's not absorbing it because they're vomiting, or it could be some genetic variability. Like if somebody has a hypoactive 2D6, they're not going to very adequately convert codeine to morphine. It could be semi-opioid resistant pain, so it works somewhat, but it's not a magic bullet. And then there are some pains where opioids really are not the answer, which is other neuropathic pains, muscle spasm, and a lot of chronic visceral or central pain syndromes, such as abdominal or pelvic pain, pancreatic type pain, fibro, and headache. So this probably isn't even your best bet to begin with. And then we have recommendations for the treatment of neuropathic pain. I do think it's important for pharmacists to recognize a lot of chronic pain has a neuropathic or nerve-related component, and prescribers should be including these adjuvant drugs as part of the patient's regimen. First line recommendations: tricyclics, the SNRIs, like duloxetine, venlafaxine, milnacipran, the calcium channel alpha-2 delta ligands, pregabalin and gabapentin, and topical lidocaine. Second line would be the opioids, tramadol, perhaps tapentadol. And then there are other third line recommendations which are not recommended very often, and some directions for the future that bear some scrutiny. So putting this all together, the next 3 or 4 slides are kind of my takeaway on this whole conversation we've had today. So somebody comes in with a prescription or more than one prescriptions. First thing I look at is this relationship between the patient and the pharmacy, the patient and the prescriber and the pharmacy. I always think of that movie with Ben Stiller when looking at that circle of trust. So do we have a circle of trust here? Asking yourself, is this patient known to my practice? Do I have a profile on this patient? Are they local to my pharmacy? Is it reasonable they would come to my pharmacy? Do I know this prescriber? Are they local to my area? Is it reasonable this patient would go to this prescriber, either because it's in the same town, or is it medically reasonable this patient would go to this prescriber for what they do for a living? Does the patient have a relationship with this prescriber prior to presenting with these scripts today? So has this prescriber written scripts for this patient before? Second, let's look at the prescription or the prescriptions themselves. A, is the prescription written for the patient standing in front of me? Did they show me their ID? Do I need to call the prescriber to verify the prescription is legitimate? If you do, use the phone number in your computer system or the phone book. Don't use the one printed on the prescription in case you think it may be fraudulent. Does this prescriber consistently order the same drugs, the same strength, the same directions? In other words, it's an assembly line. Everybody gets long-acting oxycodone and oxy-IR and Xanax or Soma or whatever. Are the most popular street drugs consistently being ordered by this prescriber? Is this just yet another case of that? Does the script look valid? Is the quantity appropriate for the scope of that prescriber's practice? In other words, if it's a dentist, why would they ever order 120 Vicodin? And for this patient's type of pain, so assess the patient's pain. Is this an early refill? Why is that? Is the patient paying cash, or are they using their prescription insurance? And then last, to look at the patient. Is or does the patient get other prescriptions filled, particularly at your pharmacy, or just controlled substances? At 49 out of 50 states, and I think the 50th is getting on board, have prescription drug monitoring programs. If you have that, and everybody pretty much does now, you should be using it like religion. I mean, that's your new best friend. Are you finding any alarming data from the prescription drug monitoring? Did the prescriber write any additional information on the script, like for chronic pain, for osteoarthritis pain? Does the patient have scripts for other CNS depressants, or just as alarming, CNS stimulants? So that's the uppers and the downers thing. I think it's important to ask the patient about the pain. It won't take you but 15 seconds, but if you start to say, where's that pain? Does it move anywhere? How bad would you rate it? And the patient gets the humma-hummas. This is not a good look. And then based on your knowledge of what you're hearing from the patient, is this an appropriate regimen? Is an opioid even appropriate for the type of pain they're having? Is the prescription suspicious in any way for this patient's pain? The quantity? Are prescriptions very similar to others from this prescriber's? And how does the patient appear? Do they look nervous? Do they look like somebody who is really suffering from this kind of pain? Although I have seen some pretty fine actors. Do they look like they're in opioid withdrawal? Are they sweating? Are they nauseated? What's going on with the patient? So again, do your symptom analysis. Ask the patient about the pain. Very important. And I'm a big believer in documentation. If you are doing your due diligence here, you can document in your computer system. Maybe some pharmacies actually have a separate documentation system. A lot of what I do for a living is hospice nurses will call me all day long and say, here's the sitch, what do you recommend, before I call the doctor. I keep notes on every single one of those conversations. I'll say, Betty called me from hospice with the example about Mr. Smith, a 72-year-old man with this kind of pain. Here's what Betty said. Here's what Betty said the drugs the patient is on. And then I'll put REC, my recommendation. And that is legally admissible. If the nurse makes an error, I can say, look, this is the conversation that we had. So it's very important to me to keep documentation. And again, I think this is important. Is an opioid even appropriate for this patient? And again, I understand you're working in a community pharmacy. You don't have access to the full medical records. And of course, we're not going to call the prescriber on every single patient. But this does give you an inkling of, is this even the right path? So my bottom line, and when PharmCon asked me to give this lecture, I said, boy, this is, I'm either crazy or just up for a really good challenge, because this is an inflammatory presentation. I mean, I don't even work in a community pharmacy, so who am I to be telling you what to do? I understand, although I have to say my sister is a community pharmacist. She's the manager of a pharmacy, and she tries to keep me grounded in reality. But I think in reading all this literature and all these expectations of the pharmacist, the ones that got into trouble were really egregious. So I would say, could we use common sense? Let's change the balance in this equation, or actually maybe keep the balance, but down with both poorly controlled pain and drug abuse and diversion. So our job is to protect our patients, our practice, our licenses, and society as a whole.